Good evening, everyone. How are you all? So this is Dr. Arshan. I am one of the mentor for First Aid AMC MCQ and Clinical. And we met earlier, I think just last week, but unfortunately my voice was like a very crappy voice at that time. I got my voice back, as you can understand, still coughing a little bit, but hopefully that will be fine. All right. So to start our trial session for AMC MCQ, we did discuss a little bit about the course last time, right? But we just finished in the middle. I think like a lot of you might missed that initial session, so we will just start over from the beginning. So just to give you some idea about AMC MCQ and also like what is actually First Aid AMC and how it get involved. So we are an Australia-based registered organization, and we mainly help the IMGs to pass this AMC, MCQ, and clinical exams. It's been like 5 to 6 years that we have been doing it. And throughout these years, we have been one of the most successful courses. And you can see that in our Facebook group that every month, a lot of candidates pass from this course. And I can say that 90% of them are first-time attempt candidate, which means that candidates come and join the course. They do the 5 months extensive course mainly, and they go for the exam in 1 or 2 months after the course is finished. And most of them pass with great score as well. So they get the confidence as well to get through this exam as soon as possible. And because most of you are working or maybe at least an intern in various hospitals, you will need that time to prepare yourself. Some of you might want to like prepare very fast and go for this exam. Even so, I always think that it is always a good idea to take preparation for at least 6 to 8 months. It will give you good confidence and you will pass the exam in the first attempt. But if you're very confident, then yes, you can go for it as early as you want. That's always possible. There is nothing like that. You have to prepare for 6 to 8 months. All right. So we can start. I can see that some of you are in Facebook live session. So if you want to come over to Zoom, then that's also fine. But if you can't, then write anything on the comment section. I will try my best to answer you. And those of you who are in Zoom session, you can always write it in the chat box. Any questions that you are having about the course or about today's session, I will be able to answer that. Okay. So let's start with psychiatry. We discussed about what is the MCQ format of AMC. So you know that it's a 150 question and you get a 3.5 hours. It's a computer-based software-like exam. We have a replica of that software-based exam. When you join the course, you will get to understand how this exam happens, and you will be able to appear multiple exams in our software before you go for real exam. Okay. Passed score is 250 out of 500. They use this scoring system, as you can see. And if you are in the middle, then you pass the exam. Now, the scoring system is always a kind of gray area for us, because AMC never reveal that how actually they mark the candidates. As far as we know that each question that you get in the exam, it does not contain similar mark. Some questions are easy question, which you might get just 1 or 2 mark. Some questions are very hard, and that might be even 8 or 10 marks. So no one knows which question carries what kind of marking. So you just need to believe yourself in that case. And also the software is designed in a way that if you answer a easy question correctly, then the next question becomes a little bit harder. The next question becomes a little bit more harder. So it just goes on and on. And if you make one incorrect, then again the same thing repeats. So that's how you get questions in the exam. A lot of candidates, when they finish the exam, they will say, all of my questions were very hard. I could not even finish the exam, or like finish reading the questions. That suggests that most likely he or she was correcting a lot of easy question and ended up getting hard question. And that's actually good, because if you can make some of the hard questions correct, most likely you are going to pass the exam. So having a hard questions does not mean that you are failing the exam. There is a chance that even if you miss a lot of questions, you can eventually pass. So that's why, like, don't get stressed after the exam. You never know that who is going to pass and who is going to fail. All right. And other than that, you should also remember that AMC MCQ has some mastery questions. Mastery questions means that those are the questions AMC thinks that a candidate should know about. Like those are must to know. So if you don't get those things correct, high chance that the software will make you fail in that exam. And what are those mastery questions? Unfortunately, no one knows. But we have some ideas that the questions, those are frequent, those are very commonly found questions. The questions related to, let's say, pneumonia, chest infection, like other chest infections, then sometimes back pain, prostate related questions. Those are usually, we think that those are mastery questions, because most of the time you will end up getting these questions in the exam. So you need to have some ideas about the questions as well. A lot of you will think that, well, why just going for a course, and why just waste the time for some theory sessions? The important thing to understand that you are preparing for Australia. You want to be a doctor in here. Obviously, you don't want to have your basic knowledge very dull or based on some question banks. Now, that doesn't mean you will not do any question bank. You will obviously do that, but that never ever gives you the basic idea that you need for passing this exam. A lot of Q banks are there in the market. Most of the time, they contain wrong answers, but you will always get some idea about the question pattern from that books or from that softwares. But please do not rely on some questions. Please do not rely on some Q banks only. Those are not your only preparatory guideline. A lot of people misguided candidates just by saying that, well, if you just do 1,000 questions from this Q bank, every questions will be there in your exam. It never does. Like in 1 in 100 might get some questions if they are very lucky, but 99% will have some difficult questions in the exam. So you need to have a good basic knowledge on these topics, which will be discussed throughout the course, and we will do most of the questions that is important for your exam. So we have question discussion class every week. We have questions discussion based on the topics that we are discussing. Like we do a psychiatry session tonight, and then we will do another 2 or 3 psychiatry classes. We finish psychiatry, we do all the psychiatry common questions. So you get all these question solvation class throughout the 5 months course, and that gives you fairly good idea about the exam questions. So there is no need for any other preparatory guideline that we will give it to you. You can just rely on us and prepare yourself and do your hard work. No one can spoon feed anyone. You have to do your hard work, but obviously the guidance is very important. Okay. Now, these are the topics that is needed for your exam preparation. So obviously we discussed medicine, surgery, gynae and obstetrics, pediatrics, mental health, population, and also you need to have some idea about ethics. So today we are mainly focusing on mental health. Although it looks like 12%, trust me, some candidates get 30 to 40% from mental health. So there is no hard and fast rule that this percentage will always follow in the exam. We discussed also that what are the books that you need for psychiatry preparation. So obviously we will need JM 8th edition. We need the Kaplan Step 2 CK books. We can also depend on some of the website like Medscape or RAND-CP. The very important basic knowledge of psychiatry comes from UWorld USMLE. The PDF books will be available in our Facebook group, the course group. So when you join the course, you will get it just through the PDF book section. Okay, and obviously you will go for this our lecture notes and then our question solvation file. So that's pretty much everything that you will need for your psychiatry preparation. Moving on. So we started depression last week, right? But because we could not finish, let's just start with depression and go forward. So major depressive disorder. It is a very important mental health condition. A lot of people in Australia suffer from anxiety and depression. So mental health is really, really important when you become a doctor in here. So to diagnose major depressive disorder, what are the criteria that you need? You need at least 5 out of these 9 symptoms that they have written. Okay, so what are those 9 criteria? The main criteria are these 2: depressed mood, loss of interest. Any of these 2 should be there to diagnose major depressive disorder. And then we have change in weight and appetite, change in sleep, can be hypersomnia or insomnia, psychomotor agitation or retardation, loss of energy, fatigue, tiredness, feeling of guilt or worthlessness, impaired concentration, attention, and suicidal ideation. As I discussed earlier, that what is the most important question that you need to ask to a patient who is having possible depression? The most important question is, do you have any suicidal thoughts or not? Or do you feel that life has a meaning? Or do you have some passing thoughts of harming yourself? So those are the important things that we ask to a depressed patient. So if the question asks that what is the most important questions you will ask to this patient, that is your suicidal ideations. Now we have a mnemonic for these 9 criteria, which is your MCQ. What is MCQ? So M for mood changes. Either you get low mood or irritable mood. Irritable mood is more common in young patient or children who has depression. Sleep changes, that's for S. I for loss of interest. G for guiltiness. E for loss of energy or lack of energy. C for lack of concentration. A for change in appetite, change in weight. P for psychomotor agitation or retardation. And S for suicidal ideation. Now, if 5 out of 9 symptoms are there for at least 2 weeks, okay, if that is the case, then you can diagnose a patient with major depressive disorder. As you discussed, that 2 key criteria for MDD is depressed mood or low mood and loss of interest, otherwise known as anhedonia. We also discussed that what are the other DSM criteria for depression. One of them is PDD, persistent depressive disorder. in which patient gets a long-standing depression for more than 2 years, but the depression will be mild severity. What is the worst prognostic factor for a depressed patient if they have associated psychosis, like hallucinations, delusion, illusions, those things? What are the atypical features of a depressed patient? If they increase weight or appetite or increase sleep. Normally, a depressed patient is supposed to get loss of sleep, loss of appetite, loss of weight. But if it's vice versa, then we call it atypical features of depression. Children and adolescents' depression, they usually follow the same criteria that we discussed just now, but children present a little bit different than adults. They usually have loss of interest, but they feel more irritable and angry. They also have school refusal. They sometimes have difficulty getting to sleep. They don't enjoy their meal, poor concentration, low school performance. Those suggest that child can have some ongoing depression. Okay. Now, children, again, if it's a mild depression, you can always send them to a psychologist for behavioral therapy, which we call cognitive behavioral therapy, CBT. If it is moderate to severe, you can think about giving some antidepressant. The first line antidepressant for any patient is SSRI. Okay. So SSRI has a lot of medications under it, but the most appropriate one for a child is fluvoxamine or fluoxetine. Next, what is recurrent brief depression? If a patient does not fulfill the criteria of MDD, rather they get recurrent episodes of depression which last about 3 to 7 days. That's what we call as recurrent brief depression. Now, in these patients, you can't give SSRI or any antidepressant because that's not usually effective. The first line management will be CBT. And if that doesn't help, then you can add lithium as a mood stabilizers. How to manage depression? The usual guideline is if it is a mild depression, the first line will be psychological therapy, which is the cognitive behavioral therapy. Moderate depression, you start with psychological therapy, does not get better, you start antidepressant. For severe depression, first line is antidepressant, and along with that, you can also consider adding CBT. Now, who are usually diagnosed as severe depression? Patient who has active suicidal ideation, that if they say that life is meaningless, or if you found that patient tried to kill themselves, or active homicidal ideation, anything which is self-harming or harming to others, that suggests a severe depression. If patient does not have any active suicidal plan, most of them you can start with cognitive behavioral therapy. Okay. If a patient having depression with psychosis, you have to add both antidepressant and antipsychotic to the patient. Sometimes patient can get severe depression and you have tried multiple medications, but still there is no improvement. And eventually patient is stopped taking all the medication. And patient also sometimes can have some belief that some abnormal belief, like a delusional belief, that they will not take any food, they will not take any IV fluid, nothing. They will just refuse everything. If you put on an IV line, they will remove that IV line. They will not have any food for 2-3 days, not even like any water. Those are severe depression or melancholic depression. In a patient who has this kind of symptom, the last resort will be electroconvulsive therapy, which is the ECT. Okay. Now, a lot of questions come from this thing, that one of the side effect of ECT is that it can cause amnesia. Now, that amnesia is not permanent, that's temporary. So that's one of the questions that comes. Another is like, let's say a patient is severely depressed and they are having active hallucination, delusion, and loss of insight. When a patient does not have insight, you can't actually take their decision properly. That means they are not medically fit or mentally fit to give consent for their medical treatment. When that is the case, and you want to give ECT, what is the procedure to do that? Anyone have some idea about it? So let's say a patient is severely depressed, having melancholic depression, and you tried everything, and the last option that you have got is ECT. What do you want to do? Yes, very good, Dr. Sani. So you go to the tribunal, and if tribunal agree that yes, you can go for ECT, then you can go for the ECT without the patient consent. Now, sometimes even you don't need to go for tribunal or court decision if you see a patient is having a life-threatening condition. That means severely dehydrated patient, then you can't wait for tribunal decision to come. If two psychiatrists agree, then you can go for ECT based on that decision. But that only the time when it is life-threatening, like a very emergency. Otherwise, most of the time you have to go for tribunal decision in case patient cannot give consent. Okay, but any patient who has mental capacity for their treatment, they can refuse every management that you offer. That they can do. Okay, now we discussed these questions previously, so let's not do that today. I will just give you a little idea about this question. Maybe some of you might missed it. So you have got a patient who who actually lost his wife 7 months ago. And since then, patient having all the features of major depressive disorder. So loss of energy, tearful, lack of interest, very suicidal ideation, okay, insomnia, then also feeling guilty about her death. So all the features of MDD are there. You have tried 3 psychological sessions and it did not help. What is the most appropriate step to treat this patient? The first thing that you think about, what is the severity? If a patient having active suicidal ideation, that is a severe depression. So you have to consider giving some antidepressant. What antidepressant you will give to this patient? Based on that, you can rule out you can rule out zolpidem, which is a sleeping pill. We don't give sleeping pill in Australia unless it is really, really needed. Reassurance recommend ECT. Not ECT, not at the moment. We can try with some antidepressant first. So you want to prescribe amitriptyline or mirtazapine? That's the question. Amitriptyline is a tricyclic antidepressant, which is the second line antidepressant. The first line antidepressant is SSRI or SNRI. Now, in this case, we normally would not give amitriptyline to a 72-year-old because it can cause postural hypotension, urinary retention, a lot of side effects. So based on B and C, mirtazapine is a very good antidepressant, especially for someone who is having trouble to sleep. So because this patient having severe insomnia, mirtazapine is a highly sedative antidepressant. So it will help the patient to sleep, and also it will act as an antidepressant. So that's why this is the best choice of action in this patient. Okay, so up to that we finished last week, right? So now let's start with this part. So side effect of SSRI is also important. What are the common side effects? Some SSRI or antidepressant can give you insomnia. Some give sedation, appetite change, nausea, dry mouth, headache, and even sexual dysfunction. The common one is nausea, tummy upset, those kind of thing. And also sexual dysfunction is quite common. As you can see that these are all your SSRI. So fluoxetine, citalopram, escitalopram, sertraline, paroxetine, fluvoxamine. So these are all the SSRI. And most of them have similar kind of side effect. All right. Now, a lot of questions come from the side effect thing. Let's start one by one. So let's say you started a patient with sertraline. Okay. Sertraline, usually we give either it's a 50 milligram or 100 milligram. So you started sertraline to a patient, and the patient coming to you with severe nausea, sometimes even vomiting, having abdominal upset. What do you want to do next? And let's say you started the patient on 50 milligram. Even with 50 milligram, patient having this side effect. And it's been you started 4 to 6 weeks ago. And patient mood is improved with sertraline. Everything is getting improved, but the side effect is there. What do you want to do next? Now, two things to consider here. One is that if this patient was on 100 milligram sertraline and patient depression was well controlled on 100 milligram, then you could consider reducing it to 50 milligram. Only if the depression is well controlled. If depression is still there on 100 milligram, then reducing the dose will not do anything. Now, if a patient is on 50 milligram, then you can't reduce the dose anymore. So what you need to do is to change it to another group of antidepressant. Why? You can't change it to another SSRI because all SSRI, more or less same, they give you the nausea, vomiting, GIT upset. So if sertraline giving it, most likely others will also give it. So you have to consider something else. Either you go for TCA, either you go for SNRI like venlafaxine, desvenlafaxine, or go for metazapine, those kind of drugs. So another class of antidepressant, not same group. Okay, so that's one of the very important questions that used to come. Now, another thing, let's say you started a patient on fluoxetine. And when you started fluoxetine on this patient complaining of sexual dysfunction, and that's affecting his marriage life. Okay. So what do you want to do next? That's the question. And let's say patient is on lowest dose of fluoxetine and patient mental condition is getting better with it. In these cases, the management is like if you have a patient who is on SSRI, like fluoxetine, or any of the drug, fluvoxamine, citalopram, any of these can give you sexual dysfunction. Yes, in that case, you have to consider what is the best approach for the patient. The first thing that you do, that if a patient is on high dose of fluoxetine, you reduce the dose. So first thing is reduction of dose. That sometimes can help. Okay. Second one is to change the antidepressant, fluoxetine, to some other class of antidepressant. Okay. So what other antidepressant you can give? There are some antidepressant which does not give too much sexual dysfunction. Like even mirtazapine, those medications are better than SSRI with sexual dysfunction. So change to another class of antidepressant will be the. And third is that if patient thinks that no, he's getting better with the fluoxetine, but only problem is sexual dysfunction, then sometimes you can add sildenafil like Viagra to this patient as the last resort. Okay, don't just add sildenafil to everyone who is having sexual dysfunction. First try with reduction of the dose or changing the drug to another class of antidepressant. All right, so that's how you manage the side effect. Any question, guys? Now, what are the side effects of mirtazapine? Mirtazapine, as you can see, severe sedation. It can give constipation, drowsiness. It can increase the cholesterol level, weight gain, because if you sleep better, you will gain weight. Insomnia is not usually the side effect, and it can also cause some change in your appetite. Then come to venlafaxine and desvenlafaxine. This is a very common medication given in Australia, known as Effexor. It also gives nausea, headache, anxiety. It can give you insomnia rather than drowsiness. You can also get ejaculation disorder, dry mouth, sweating, weight loss. But the most important side effect of venlafaxine is that it can give hypertension. It can increase the threshold of seizure. That means a patient who has epilepsy, you should not give venlafaxine. Sometimes it can also give you hyponatremia. So let's say an elderly patient recently started with venlafaxine and now coming to you as confusion. So very confused, having active delirium. And you found out that this patient was recently started with some medication. One of them is venlafaxine. Immediately think that most likely it is a hyponatremia causing the confusion. So you just check the electrolyte level, you correct it, patient is better. Excuse me. Next, serotonin syndrome. Very important. Sometimes you will find out time to time in exam that serotonin syndrome comes frequently. So what is this serotonin syndrome? It is an adverse reaction, rather serious adverse reaction for use of SSRI. So what is SSRI? It's a serotonergic medication. That means it increases serotonin in your blood. Now, if you take multiple serotonin increased drug, that can cause this serotonin syndrome. That means it's a toxicity of high level of serotonin in your body. What usually happens that sometimes one doctor started antidepressant, patient taking that, And patient went to another doctor, maybe 2-3 weeks later, and that doctor given another antidepressant. Unfortunately, patient did not say that he is already on an antidepressant. So now patient taking 2 antidepressant, having same kind of SSRI. So that's one of the reasons how they can end up getting a serotonin syndrome. Sometimes even with a high dose of one SSRI, patient can get this problem. So what are the drugs that can increase serotonin level in your body? Any antidepressant, like either it's SSRI, SNRI, TCA, MAO inhibitors, whatever it is, they can increase serotonin. Opioid, especially tramadol, can increase it. Stimulant drug, like any of the illicit drugs, antiemetics, lithium, and psilocybin. So these are the main medications that can increase serotonin. Sometimes even if a patient is having a binge alcohol drinking, that can also increase the serotonin level. To diagnose serotonin syndrome, we need 3 symptoms. What are those? One is CNS involvement. So patient will have altered level of consciousness, sometimes manifested as agitation, confusion, sometimes even seizure or convulsion. Altered muscle tone. So patient can get tremor, shivering, myoclonus, and hyperreflexia. Autonomic instability. They can get hypertension or hypotension. They can get tachycardia, high fever, and diarrhea. So these are basically the feature. So a patient who is taking antidepressant and recently increased the dose, coming to you with recent change in their mental status, having high fever, drowsy. On examination, you found patient is hypertensive, tachycardia, having hyperreflexia. That's the time you think about serotonin syndrome. The management is immediately stop all the drug which can increase serotonin. Most of the time, we gradually reduce the dose of antidepressant to make sure they don't get any withdrawal symptom. But when they get serotonin syndrome, you stop all the drug immediately, like all the drug which can increase serotonin. And then give some supportive treatment. Like if it is a high fever patient, you can give cool blanket. So just like conservative management. Sometimes even after conservative management, if patient is not getting better, there is an antidote of it, which we call cyproheptadine. So that cyproheptadine can be also given at the last resort. So this is how they look like. As you can see, they look very startled, agitated, confused. They will have a lot of sweating, agitation, diarrhea, hypertensive. You can get hyperreflexia. You can get clonus positive and tremor. And also one of the important findings that their eye or pupil will be dilated, which is mydriasis. Now, while we are discussing about serotonin syndrome, there is another syndrome called neuroleptic malignant syndrome. Now, that is a complication of using antipsychotic drug. So when we will come to antipsychotic drug, you will know about it. But neuroleptic malignant syndrome and serotonin syndrome can be very confusing in the exam. So think about a couple of things to find out or differentiate between these two. Serotonin syndrome, obviously patient will be on multiple antidepressant, whereas neuroleptic malignant syndrome, they will be on antipsychotic drug. The main feature of serotonin syndrome is that they get tremor, myoclonus, whereas in neuroleptic malignant syndrome, main feature is that muscle rigidity. So muscle becomes very rigid. Reflex will be increased in serotonin syndrome, decreased in neuroleptic malignant syndrome. Pupil will be dilated here and normal in NMS. Okay, So that's how we differentiate between these two. So that's actually your side effects of medications. Medication side effects come in exam a lot. So you have to know the basic side effects for the common medication that is used. Now let's say that you started a patient with antidepressant. How long will you continue it? When the patient gets better, will you stop it? No. It is recommended that you continue it for a minimum of 12 months if it's for the first time. If patient having multiple episodes of depression, then 2 to 3 years. Some guidelines say 3 to 5 years. So whatever it is, at least minimum 2 to 3 years for recurrent depression. All right. So that's pretty much everything about depression. Any question, guys? All good? Are you understanding me, guys? Like, am I very fast for you or any problems so far? I don't think so, Dr. Madiha, that imipramine is like, we don't use imipramine in children as a first line because it's under TCS. So that's not even the first line drug. I'll have to check. Very good question. I don't know who you are. Your name is coming as Galaxy F50, but good question. So when you change SSRI, how you do it? Let's discuss about it a little bit. So let's say that a patient was on fluoxetine, and now you want to change the medication to sertraline because this is not effective for a patient. And when we call it ineffective, so that's also another thing. When you start a patient with an antidepressant, you should continue it at least 4 to 6 weeks to say that it is not effective. All right, so 2 to 4 weeks, you will check the patient. If there is mild improvement of the mood, you continue it for 4 to 6 weeks, sometimes even 6 to 8 weeks. So even after that, if it is not getting better at all, that means that antidepressant is ineffective. So you change this fluoxetine or any of the antidepressant to another one. Now you can do that like a same class at that time, that's fine. But when you do that, there are some antidepressant like some SSRI, which stays in your blood for few days, even after you stop it. Like fluoxetine, it stays in your blood for at least 7 days. Even you stop it today, the effect of fluoxetine will be there for at least a week. So at that time, if you start another antidepressant, what can happen? You stop the antidepressant and you are thinking patient is on only one medication. But what you have done, guys, you can cause serotonin syndrome, right? Because patient already in her body, fluoxetine is there. Now you started another antidepressant, even though you are thinking that you stopped it. So you can get a serotonin syndrome at that time. To avoid that, we give a break, you can say kind of like break in between two antidepressant. For fluoxetine, we give at least 1 week washout period. So what we call it, washout period. So you gradually reduce the dose of fluoxetine and then you stop it. 7 days break, and then you start low dose sertraline and gradually increase it. That is how you change the antidepressant. Okay? So that's how we should do it. Some might not need anything. Some will need 1 week. Most of the time, for the purpose of the exam, at least give a washout period of 2 to 3 days. If it is fluoxetine, at least 1 week. And when you want to change SSRI, the group you choose, it depends on the patient symptom mainly, like what you want to treat. If a patient having sleeping problem, give them mirtazapine. Okay? Sometimes you can also, if mirtazapine is not in the question, then choose TCS, any of the tricyclic, like amitriptyline, nortriptyline, those drugs. Sometimes even SNRI, like venlafaxine, desvenlafaxine, those are also a good choice. Moving on to bipolar disorder. So depression is all done. Okay. I don't think that there is any question which can come under depression at least. Bipolar disorder, when a person has two kind of mood, like you can see the picture here, sometimes this is the normal mood, sometimes mood becomes very good. That time patient is actually in a manic phase, that is mania. And sometimes mood goes down like this, there is the depression phase. When a patient has mood swings like this, sometimes mania or hypomania, and sometimes depression, that's the time we call it bipolar disorder. So first of all, let's talk about mania. So how we diagnose mania? At least 1 week of abnormally elevated mood. Along with that, at least 3 of the following features. So patient will have high self-esteem or grandiosity. That means they will feel like they have superpower. They might also say that they are going to win Nobel Prize, something like that. Very unusual kind of hope. So increased self-esteem or grandiosity. They will have a lot of energy. They will have decreased need for sleep. They will be very talkative and loud in speech. And they have a very, very characteristic kind of speech, which we call a rapid pressured speech. Their thought will be racing and jumping from one to another. We call it flight of ideas. They will be very destructible and increased goal-directed activity. That means a person who never ever like joined any club or did not go any social gathering suddenly started to join multiple community club, going to the libraries, going to swimming club, surfer club. So a lot of activities suddenly. That is what we suggest as mania. And excessive activity, which is mainly like kind of reckless behavior. So increased spending of the money, gambling, reckless driving. So those kind of things also is a characteristic of mania. So high mood or elevated mood, along with that, if a patient showing these symptoms like very loud, talkative, pressured speech, jumping of ideas or flight of ideas, patient having reckless behavior, increased goal-directed activity, high self-esteem, if it persists for at least 1 week and it affects their social, familial, occupational life, that is what we call as mania. What if the symptoms are not severe enough and the duration is less than a week? At that time, we call it as hypomania. Okay, so mania, hypomania, there are two terms. Now, this mania feature, we have a mnemonic for it called DIC first. So D for destructible, I for insomnia, G for grandiosity, flight of ideas, increased activities, itch pitch, and thoughtlessness, which is mainly the reckless behavior. Okay. Now, bipolar 1 disorder, a 19-year-old student is taken to the school counselor after he fails several classes. Patient is enrolled in numerous classes, most of which have conflicting times, so increased goal-directed activity. Grades are poor, but he is undisturbed by this. He is also enrolled in numerous organizations such as chess club, drama club, student government, sports, and at least 2 other fraternities. Each piece is pressured and having psychomotor agitation. What is psychomotor agitation? Patient will be very restless, like running all the time. So bipolar 1 disorder, if a patient having this kind of manic episode and at least sometime patient also showed features of depression, that is what we will call as bipolar 1 disorder. So bipolar 1 disorder has one fully fledged manic episode and one depressive episode. So when a patient at least have one depressive episode and one fully fledged manic episode, that is bipolar 1. And if a patient have depression, but hypomania, not mania, that is what we call as bipolar 2 disorder. These are some of the symptoms as we discussed. So hypomania is the term used to describe the symptoms of mania that are similar but less severe and shorter duration, usually less than 4 days. Now, how we manage acute mania? Acute mania is a medical emergency and they need to be hospitalized. Now, if a patient with acute mania says that I will not get admitted, can you do anything about it? Will you keep the patient in hospital without the patient consent, or you'll just let them go? Guys? Yes, you have to keep the patient because that is called involuntary admission. So that patient, even if he does not want to be admitted in the hospital, under Mental Health Act, you can keep the patient in the hospital. Okay? So these are some of the exceptional cases that when patient consent will not act. When someone is either in self-harm risk or their risk to others, then you can admit them involuntary under Mental Health Act. Okay. Now, what is the most effective medication for acute mania? Antipsychotic. So first line management is antipsychotic. Either you start the patient with risperidone or olanzapine. Between risperidone or olanzapine, we will choose risperidone mainly because that is commonly used in Australia. Okay, so risperidone or olanzapine, this is your first line medication for acute mania. What are the second line? Sometimes you can use second generation antipsychotic or even a first generation like haloperidol. You can use lithium. You can use other mood stabilizers like sodium valproate or carbamazepine. These are all second line. Okay. Now let's say these are all oral medication and patient is very agitated and you can't give them oral medication. Then you have to give them some IM or IV medication. So that time you can give haloperidol IM. Okay. Now, if a patient have recurrent bipolar disorder, especially 2 or more episodes of either mania or depression in previous 4 years, that patient fulfills the criteria to get a prophylactic medication to prevent this recurrent attack. And what is the best prophylaxis for bipolar disorder or mania? Lithium. So lithium will be the best management. Other than lithium, you can use any of the second generation antipsychotic like olanzapine, risperidone. You can use some mood stabilizers also like carbamazepine or sodium valproate. If you start lithium, that has to be at least 3 to 5 years. When you put a patient on lithium, there is always a risk of side effect from it. So if you think that patient is having any side effect of lithium, you can always check their lithium level in the blood. So what are the side effects of lithium? It can give you a tremor, muscle weakness, weight gain, GIT side effect, hypothyroidism, and nephrotoxicity. These are the two important ones. So hypothyroidism is one of the important side effects of lithium. So you have to check their thyroid function. Nephrotoxicity, especially lithium can cause nephrogenic diabetes insipidus. So that's why anyone having lithium, having any kidney failure or kidney involvement, think about possible side effect from lithium. Now, there are some other features of lithium toxicity. So mild features are nausea, vomiting, tremor, hyperreflexia. Moderate, patient gets a rigid, hypertonia, and hypotension. And severe cases, they get cardiovascular collapse, seizure, and even coma. So if you think that patient having lithium toxicity, you have to measure the lithium level in the blood. If lithium level is high, then obviously you have to treat the patient as soon as possible and stop lithium. First line treatment will be hydration. So always hydrate this patient because they get dehydrated a lot. Anyone knows any other medication which can reverse the lithium toxicity? There is no known antidote for lithium toxicity. Okay, so in case, sorry guys, in case that if you get a patient who is having lithium toxicity and you see that patient having a seizure or cardiovascular collapse or renal failure, if any of this happens, then you have to go for dialysis in those patients. Okay, that's usually the last option. Again, lithium goes more than 4, choice is dialysis. Okay. Now, how we manage a bipolar depression. So time to time, what happens that you started a patient with antidepressant because patient presented to you with features of depression. Now, when you started antidepressant, that patient actually came back to have an acute mania. What is the reason? Because most likely that patient was a bipolar patient. And if a bipolar patient only gets antidepressant, it can precipitate an attack of mania. So that's why you have to be very careful when you offer antidepressant. So anyone having a bipolar depression, that patient should have both antidepressant as well as a mood stabilizer, any of it. Like you can give olanzapine, risperidone, you can give even lithium, valproate, any of these are fine. And once you start it, you will withdraw the antidepressant within 1 to 2 months and then keep on using the mood stabilizers. So that's how you treat a patient with bipolar depression. Very important. Comes in exam frequently. Now we have got a question to discuss here. So you guys will answer it, right? 27-year-old man brought to the office by his wife due to the concern that he has not been himself for the last 3 weeks. She says that he is depressed and withdrawn, sleeps 14 hours a day for interest. Patient was hospitalized 6 months ago for an episode in which he became aggressive toward his wife. This occurred when she confronted him about staying up all night, gambling away their saving, investing a large sum of money in a startup company that soon went bankrupt. At that time, patient spoke very rapidly and convinced that he had a brilliant plan to achieve world peace. He also experienced similar episode 2 years ago. Which of the following medications are most appropriate for maintenance treatment of this patient? Carbamazepine and fluoxetine, lithium and quetiapine, lithium sertraline, lurasidone risperidone, valproate clozapine, valproate haloperidol. So what do you think? So this patient had a mania, now having depression. So it's a bipolar depression patient now. So you have to choose an antidepressant as well as a mood stabilizers. So find that out. Carbamazepine is a mood stabilizer. Fluoxetine, it's an antidepressant. Okay, that's a choice we have. Lithium and quetiapine. Lithium is a mood stabilizer, good one, and quetiapine is a antipsychotic. Now, do we need to give both? Because both of them are part of mood stabilization. So this one doesn't need, because quetiapine is an antipsychotic, lithium is a mood stabilizer. We need one antidepressant, one mood stabilizers. Lithium, mood stabilizer, sertraline is an antidepressant. So this is a good one. Lurasidone, risperidone, both of them are antipsychotic. Valproate, mood stabilizer, clozapine, antipsychotic. Again, no need. Valproate, haloperidol. Again, same thing. So only thing is between A and C. Now, based on that, the best option is always lithium if you have. So use lithium and an antidepressant, which is a sertraline. So C will be your option. Okay. See that how you can use your theory knowledge to solve the questions. That is actually what I want you guys to understand. And you guys obviously need this knowledge at least to understand why we are choosing C here out of all of these options. So next one is persistent depressive disorder, also known as dysthymia. Dysthymia, we already said that if a patient having low severity of depression and persist for at least 2 years, that is PDD. PDD patient gets benefit from psychotherapy first. If psychotherapy doesn't help, you can offer antidepressant. There is another condition called cyclothymic disorder. So one is dysthymia, which is your PDD, and cyclothymic disorder means that it's a chronic disorder lasting for 2 years and who has many episodes of depression and many episodes of hypomania. So if a patient have like many periods of depressed mood and many periods of hypomanic mood for at least 2 years, that is what we will call as cyclothymic disorder. Have a look at this question. So Mr. McDonald has experienced 12-year history of periods of feeling great, followed by periods of feeling lousy. During her feeling great period, she experienced increased sexual drive, euphoric mood, and increased irritability. So that's mania. During her feeling lousy period, she feels insomnia, fatigue, low self-esteem. So that's depression. So more than 2 years having bipolar features, that's cyclothymic disorder. This patient also get benefit from mood stabilizer like lithium. All right. Now, we have only one thing to discuss from depression and this bipolar thing, and then we will take a break and we will start with the schizophrenia after break. So what is actually grief and how we differentiate grief from depression? Very important. Comes in exam in a lot of ways, and understanding the difference is also very hard because both of them has kind of similar symptom. So grief or bereavement usually follows someone dead, like someone who you love, someone who you used to live for a long time, and suddenly they are dead or deceased. Usually, grief or bereavement follows someone you lose, someone you used to love or used to live with. So after that, you get intense sadness, tearfulness, decreased sleep. So lot of features similar to depression. But these things should not persist for more than 6 months. So less than 6 months, patient having these symptoms, that is normal. You just diagnose them to have a normal grief or bereavement. When it becomes more than 6 months, that's not normal. And the term we use for them is called complicated bereavement. Okay? Both of them can get benefit from psychotherapy. Whereas depression, obviously, if anyone fulfills the criteria of major depressive disorder, your diagnosis will be MDD. Now let's discuss this question. Excuse me. 50-year-old woman taken to the hospital after neighbors find her wandering the streets, mumbling to herself and gesturing. When approached, she begins to cry and expresses thoughts about hurting herself. Examination reveals a scratch mark on both forearms and laceration on the throat. When questioned, she repeats feeling depressed since her husband died 5 months ago. She reports a decrease in concentration, feeling helplessness, hopelessness, anhedonia, quit her job, staying at home. She now has begun to hear her husband's voice asking her to join him. Which of the following would be the next step in management? Now, when someone has this hallucination or delusion, like hearing the voice, this is a auditory hallucination. Now, that is not very normal. That patient most likely has got severe depression, or you can say complicated grief with psychotic features. Okay. Now, what do you want to do next? You want to begin a trial of antidepressant, refer to psychiatry, refer for ECT, assess for thoughts about suicide, refer to outpatient department for follow-up. Remember one thing, this patient is suicidal. The next management, in exam, you will find out they're asking what is the most appropriate management. Most appropriate means the definitive management. But if they ask what is the next management, that means what is your initial management for this patient? Initial management is you have to assess her thoughts for suicide. Because you need to find out that what is her thoughts. Does she have a plan? If yes, then what kind of plan she is having? Is it an active plan that she wants to suicide right now? Because if it is the case, you have to send the patient to the hospital. So always, if in the exam question that there is a choice that assess for this, always choose that. Like most of the time, that is the answer, because you always assess first that what about this? Is this patient actively suicidal? So assessment comes first, and then you choose the next step. Okay. All right. So that's about depression and bipolar disorder. Let's take a 10-minute break. And after the break, we will have a schizophrenia and antipsychotic drug discussion. All right. So take a break, have some drink, and then just come back. Okay. Thank you all. All right, so let's start again, guys. Schizophrenia. So schizophrenia is very, very important topic for exam. So see that this depression, bipolar disorder, and schizophrenia, these three topics is the most important topic for your psychiatry. Many questions will just come within the discussion that we have done tonight. Okay. So schizophrenia or psychosis means that when a person loses touch with the reality, that's when we call them as schizophrenia. So they have an inability to interpret reality. And if these symptoms present for at least 6 months, then we can diagnose them as schizophrenia. Now, go through these risk factors and everything, but prevalence is important for exam. So they ask you, like, if both parents had schizophrenia, then what is the chance of getting it in the child? So 2 schizophrenic patient, 40% chance. 1 schizophrenic parent, 12%. 1 first degree relative, 12%. Second degree relative, 5 to 6%. Like if let's say one like grandmother had schizophrenia. So what is the chance of getting this schizophrenia in the child? 5 to 6%. General population only 1%, monozygotic twin 47%, and dizygotic twin 12%. So this percentage comes in exam, so you have to just memorize that. So how we diagnose a patient with schizophrenia? The guideline says that if a patient has 2 or more of the following symptoms, these 5 symptoms is what we call as schizophrenia symptoms. They are divided into positive symptom and negative symptom. Positive symptoms are hallucinations, delusions, and disorganized speech. So what is delusion? Delusion means an abnormal belief that even if you give proof to the patient that no, this is not right, your belief is not right, still after that, patient believes that no, whatever I am thinking, that is the right one. So even after giving a proper explanation and result of the belief, patient still believes that that's delusion. Hallucination means abnormal perception. So if you see a snake in front of you, but I can't see that, that means you are having a visual hallucination. If you are hearing some voices that no one else can hear, that means you are having auditory hallucination. If you can feel that someone is crawling underneath your skin, but there is nothing in your skin, that is tactile hallucination. If you get an unusual taste, but actually you don't have any problem with your taste bud, that is a gustatory hallucination. So those are the hallucinations that is important for exam. Especially visual and auditory is important. Then you have disorganized speech, which means that the speech is not understandable. Like whatever you are saying, it doesn't make sense. So that's disorganized speech. To diagnose someone with schizophrenia, you need at least one of these 3. So that's must. Okay. Sorry. And also, along with that, patient can have grossly disorganized behavior. Like you will understand patient is unkempt, very untidy, having inappropriate dressing. So that's disorganized behavior. And there are negative symptoms, which is like flat affect, social withdrawal, poverty of thought, which means that you can't think like a normal person. Sometimes flat affect means that whatever happenings beside that patient, they don't actually care. So everything is flat. And social withdrawal is also very important criteria. If these symptoms persist for at least 6 months, then we call them as schizophrenia. So you need to find out that if a patient having hallucination, delusion, disorganized speech, disorganized behavior, and flat affect, that is the time you diagnose them with schizophrenia. And duration is very important because less than 6 months, the diagnosis will be different. We'll come to the point later on. So these are your positive symptoms. Positive means that it doesn't mean it's a good symptom. It means that a normal, healthy individual does not have these symptoms, but a schizophrenic patient has this symptom. That means it's a positive symptom. So delusion, hallucination, thought disorder, sorry, disorganized speech. And negative affect means that a normal person have this kind of feature, but schizophrenic patient does not have it. That means a normal person affect should be normal, right? Not flat. So flat affect, poverty of thought, lack of motivation, social withdrawal, even reduced speech output. Those are the negative symptoms of schizophrenia. Always try to rule out drug-induced psychosis if a patient taking a lot of stimulant or recreational drugs or illicit drug. There is always a chance that the symptoms that patient is showing, it might be just drug-induced psychosis. So you should always consider one of the differential diagnoses that it can be just recreational drug-induced psychosis. Management. In psychosis or schizophrenia, medication is your first line management. So among them, what is your first line? We previously, long time ago, people used to use like typical antipsychotic, which are like haloperidol, those kind of drugs, which have a lot of side effect. Nowadays, we no longer use haloperidol or any of the first generation antipsychotic as our first line. We use the second generation antipsychotic, and those have less side effect. And among them, risperidone and olanzapine is our first line choice. Between these two, risperidone is our first choice. If response is inadequate in 3 weeks, then you can increase the dose. If there is no response after 4 to 6 weeks, then consider changing this antipsychotic to another second generation. And last option would be to change it to a first generation one, which is chlorpromazine, haloperidol, trifluperagine. So very unlikely we don't use this anymore here. Haloperidol sometimes we use, especially if a patient is acutely distressed, like acute psychotic patient who is very violent, removing removing the IV lines, attacking the patients or the doctor. That time we give the IM haloperidol just to settle the patient down. Sometimes you can always give IM olanzapine also. Okay, so any of these two is your choice. So now let's say, what is drug-resistant schizophrenia? If you try 3 antipsychotics and you use the maximum doses of those 3 antipsychotics, still patient symptom is not relieved, that is what we call as drug-resistant schizophrenia. The last resort for that patient before trying the ECT would be giving a trial of clozapine. Clozapine is a very effective medication, but because of its bad side effect of blood dyscrasia, cardiotoxicity, we normally don't give clozapine to any patient unless it is really needed. And if patient still fails to respond with clozapine, then you have a choice of ECT. All right, so that's actually the management of in any schizophrenia patient. So first line medication would be your second generation antipsychotic, either olanzapine or risperidone. Then there are others as well, like you have quetiapine, aripiprazole. Those medications are also available. We will come to the side effect of those medications just in few minutes time. Now, I guess you guys know about extrapyramidal side effect, EPS. So extrapyramidal side effect is a very common side effect of using antipsychotic drug. So one of them is acute dystonia. In this case, patient get kind of a bizarre muscle spasm of their face, neck, tongue, and trunk. Sometimes even you will see that their eyes are like a dancing eyeball, which we call oculogyric crisis. Sometimes they will, or arching of their back, like back will become arched like that. That is opisthotonous. So these are what we call as acute dystonia. And at that time, you just give the patient benztropine, and that can relieve this side effect. Then there is akathisia, which is subjective restlessness in a patient. So patient will complain that my legs are always moving. I can't sit around. I feel I have to just change my position all the time. So that's subjective restlessness. And the treatment, first, you can reduce the dose. If reduction of the dose is not possible or does not help, then you can give either oral propranolol, diazepam, or benztropine. Any of these three is fine. Okay. Next, Parkinsonian. Now, it's not Parkinson disease, but patient with Parkinsonia, like patient with this kind of problem, they can get a side effect similar to a Parkinson patient. So what usually they present with, that they will have this motor disorder associated with Parkinson. So Parkinson patient have a specific gait disorder, and they are very slow. So bradykinesia, rigidity of their muscle, and also a particular gait of Parkinson will be there. So if there is a motor Parkinson-like symptom happens after using the antipsychotic, most likely this is extrapyramidal side effect. So either you lowered the dose, or you can use either benztropine or benzhexol in this population. Okay. Then there is tardive dyskinesia. Tardive dyskinesia, it's a abnormal involuntary movement of face, mouth, tongue. So they have this involuntary movement of the muscles of face and mouth. Now, this usually comes after a prolonged use of this antipsychotic, not just immediate. So it's a long-term antipsychotic drug side effect. In that case, first of all, if it is really bothering the patient, you can stop the medication. If drug withdrawal is not effective, then you can use tetrabenazine for this patient. Now, these are not very important for exam. Only thing that I have seen is the akathisia that is important. And then there is the neuroleptic malignant syndrome, which we have discussed a little bit. So a patient taking antipsychotic drug, if they present to you with a high temperature, muscle rigidity, altered mental status, and the reflex is reduced, think about NMS. Treatment, stop the medication immediately and hydrate the patient with IV fluid. If it is life-threatening, you can give either bromocriptine or dantrolene. Okay, because antipsychotic drug can reduce dopamine in your brain. So as an antidote, you have to give something which increases dopamine. So bromocriptine is one medication which can increase dopamine in your blood. So that's why we give bromocriptine in this patient. Now, the most important out of all the discussion of schizophrenia is this chart. Side effect of this medication comes in exam in a lot of ways, and a lot of questions has come in the exam. So you have to have a good idea about it. And the common medication, not you don't need to know about lurasidone. We never give it. So the common medication is aripiprazole, clozapine, important because it sometimes we need that, olanzapine, quetiapine, and risperidone, and very rarely ziprasidone. So these are the common medication side effects that you need to know. Have a look first with aripiprazole. Aripiprazole, the main side effect is that it can give you orthostatic hypotension or postural hypotension. But it is a very good medication based on side effect. Like it has least side effect, you can say. So it does not increase blood glucose. It does not cause hyperprolactinemia. It does not cause sedation or weight gain. So that's usually a very good side effect profile. Looking at others, like let's say clozapine. Clozapine, you can see that it causes dyslipidemia, so high cholesterol. It causes hyperglycemia, so possible diabetes. It causes postural hypotension, and significant one, highly sedation and weight gain. So all of these side effects are there. Okay, so that's one thing. Olanzapine also has similar side effect like clozapine. That means they usually give you the metabolic syndrome, increased weight, increased blood glucose, increased cholesterol. So these are the side effects of olanzapine also. So dyslipidemia, hyperglycemia, sedation, and weight gain. Now look at the quetiapine. It also give you similar kind of thing, like it can give you hyperglycemia, weight gain, all right? But good thing is that it does not give that much hyperprolactinemia. So for hyperprolactinemia, this is a good medication. Best is aripiprazole. Look at risperidone. Remember, risperidone, the most important side effect is hyperprolactinemia. And also it can give orthostatic hypotension. Okay. Now that you know about it, let's discuss some questions which is important. Let's say you have started a patient with risperidone, and now the patient coming to you with galactorrhea. That means whitish discharge coming out from the breast. So that means if galactorrhea is there, that means prolactin is high, most likely. So risperidone can cause hyperprolactinemia, right? So in that case, you have to change risperidone. So what medication is best choice for hyperprolactinemia? The best choice is aripiprazole. If aripiprazole is not in the option, then we will choose quetiapine. Very important question, comes frequently. Now let's say we started a patient on olanzapine, and now the patient is gaining weight, sometimes even high blood sugar. What do you want to do? That patient needs to be changed to aripiprazole as well, because this is the only medication which does not give you weight gain, does not increase your blood glucose or cholesterol. All right, so this is how question comes. So they say that a patient is on risperidone and started to have whitish breast discharge, having amenorrhea. So what do you want to do next? The next thing that you do, you change the medication to aripiprazole. Now, when you change medication like antipsychotic, How we change the medication? Now, do we need to give a washout period like antidepressant? No. We use a cross switching. What is cross switching or crossover? Let's say you want to change risperidone to quetiapine. What you have to do that you will gradually reduce the dose of risperidone. At the same time, you will also use a low dose of quetiapine, and you will gradually increase the dose of quetiapine. So that means you reduce the dose of risperidone, gradually you taper it down, and you also start quetiapine at the same time as a low dose and gradually increase the dose. And at one point, you stop risperidone totally. Okay, so that's crossover period. Usually during this crossover, patient needed to be admitted in the hospital to reduce any possible side effect. Excuse me. So far clear, guys? I know that for the first class, this is a lot to take. Now, we have some other psychotic disorders. One of them is called brief psychotic disorder. So what is this brief psychotic disorder? Now, brief psychotic disorder patient will have features of schizophrenia, but that will last less than a month. So a 35-year-old female Chinese immigrant is brought in by neighbors after she was found wandering in the streets, yelling out someone's name. She appears disheveled and grossly disorganized. So that's one feature. You learn that she arrived in US several days ago, and upon her arrival, witnessed the death of her 3-year-old son. While in the waiting room, she appears to be responding to internal stimuli. This is an indication or clue for hallucination. When someone responds to internal stimuli, that means they are actually either seeing something or hearing someone. So that's hallucination. So you have got two features. That suggests that this patient have a psychosis-like feature. But because it is less than a month, it is what we will call as brief psychotic disorder. So symptoms more than 1 day, but less than 30 days. Now this patient also will need antipsychotics. Next is schizophreniform disorder. Now the same features of psychosis, but the duration is the main difference. So symptoms will be there for more than a month, but less than 6 months. So all the hallucination, delusion, disorganized speech are there, but only difference is the duration. More than a month, less than 6 months. That is what we will call as schizophreniform disorder. This patient also we will need antipsychotic medication. Now, so we got an idea that less than 1 month, it's brief psychotic disorder. 1 to 6 months is schizophreniform disorder. More than 6 months is schizophrenia. So what is this schizoaffective disorder then? Now, that is a little different than others. Have a look that it has two parts. One is schizo, another is affective. Affect means mood. So they are talking about either depression or mania by affect. So when a patient has both psychotic feature as well as affective feature, either depression or mania, that is what we will call as schizoaffective disorder. Now look at this question. A 25-year-old woman is found walking nude in the shopping mall. When asked why, she replies, I am making it easy for others to have sex with me since I know they all want me. She states she heard a voice telling her she was irresistible. Everyone wanted her. When she speaks, she can't focus on one topic at a time. So that's a clue. Her mood is euphoric, affect labile. So what these things are they are talking about? Nice. So when she speaks, she can't focus on one topic. Her mood is euphoric. That is mania, right? This patient having mania now, and she also heard a voice. She's having a disorganized behavior. So this patient also having psychosis. She recounts an episode last year where although she did not have an elevated or depressed mood, she heard voices she could not describe. These symptoms lasted for more than 6 months. So, excuse me. So, schizoaffective disorder, patient will have active depression or mania along with features of schizophrenia. So, our patient had psychosis, our patient had mania. With that, there will be delusion or hallucination for at least 2 weeks in the absence of any other mood symptom. So that is actually this last year when she only had some hallucination. That is what is also an important criteria. So at the moment, she is having mania as well as schizophrenia, that is schizoaffective disorder. But last year, she also had just a psychotic episode. So when that is present in your exam question, you diagnose them as schizoaffective disorder. For this patient, you have to start the patient with antidepressant. If antidepressant not effective, then you have to add antipsychotic as well. Okay. And if a patient is having mania, then you use like mood stabilizers like lithium or sodium valproate like that. All good, guys. Schizoaffective disorder. This is a little hard to understand, I guess. So if you have any questions, just let me know. The last one tonight we are going to discuss is delusional disorder. So when someone only has delusion, no other features of schizophrenia, that is what we will call as delusional disorder. So Mr. Smith has been married for 10 years. During most of those years, he believed his wife was trying to poison him to get his money. He frequently complains stomach pain, which he believes is due to the poison. Thoughts are logical and coherent, denies any hallucination. His wife, an independently wealthy woman, does not understand her husband's logic because she has more money than he does. So as you can see that this abnormal belief did not affect the patient life, right? Because they are still married. So that one criteria, that delusional disorder does not affect a person's familial, occupational, or social life. And they don't have any thought problem, so no disorganized thought, no hallucination. Only thing that is the belief that he is having. So these are called non-bizarre delusion. That means delusion which are plausible. That means possible. Yes, it can happen. Like not if I think that I have worms in my brain, or if I feel like my soul is detached from my body, those are called impossible or bizarre delusion. And bizarre delusions are features of schizophrenia. Non-bizarre are like there is always a chance that it can happen. Like, yes, poisoning can happen, right? And these symptoms should be there for at least a month. no impairment in level of function. Management, you can actually give this patient some antipsychotic medication if you want. Now let's discuss some questions. A 37-year-old woman is brought to the emergency department by police after she was found trespassing on famous film actor's estate. The patient is excited and says that this is all a big misunderstanding. She explains that, excuse me, she was only trying to leave the actor a surprise gift and a note and would never harm him. She recently received a signed photograph in response to one of her letters and keeps it in a box filled with newspaper and magazine. The patient says, for now, we need to keep our relationship secret. Although she hasn't met the actor in person, she is convinced that they will be together someday. Patient has worked for many years as an administrative assistant. Although she has no difficulty performing her job, she keeps to herself as she feels that her co-workers do not understand her relation. She is calm and cooperative, speech fine. The patient says her mood is wonderful because I am in love. Which of the following is the most likely diagnosis? What do you think? Bipolar disorder, borderline personality disorder, delusional disorder, narcissistic, schizoid, or schizophrenia? Now, let me say that none of the personality disorder is your answer. We will discuss this in our course. But is it schizophrenia? No, because she does not have any hallucination. Her speech is fine. Only thing she is having is delusion. And the most important is that she is working. It hasn't affected her life. So that is your delusional disorder. Okay, good. So last question. A 70-year-old man hospitalized due to severe depression and a 9-kilo weight loss over the last month. Family members report that he has become progressively withdrawn from friends. He stopped attending his weekly bridge game, refuses to leave the house. He sleeps poorly. The patient has a history of depression and responded to treatment with a tricyclic antidepressant. A recent trial of SSRI was ineffective. History of hypertension and MI. In the hospital, efforts to get him to eat are unsuccessful and he barely drinks. So that is something which is very important. Mental state examination, patient eyes are downcast. He gives brief, barely audible response. He reluctantly discloses that he has been hearing voices of his brother. What is the most appropriate treatment? Antipsychotic medication, cognitive behavior, ECT, monoamine oxidase inhibitor, SSRI, TCA. Now, this is a patient who is having melancholic depression with psychosis, and you have tried medication. What is the most appropriate? If they ask most appropriate, that means the definitive management. In that case, the choice will be ECT. The important is that you don't have time to try with the medication anymore because this patient is going to die in few days if he is not eating at all. So for that case, ECT will be the best approach. All right, so that's all about our today's class, guys. I hope you enjoyed the session. Now, before we finish, I would just give you a little bit idea about the course that's going to start from next month, 3rd of July. And also remember to join our free 2-week session starting from 3rd of July. Okay. Now, free 2-week sessions, you will get to know more theory sessions. We will give you some question solvation class as well, so that you can understand how we take the question class. And mainly that if I want to discuss the course detail, you already know from it from the Facebook group, right? We have given the full detail of it. So this is a 5 months course. The main summary is we are going to discuss the full theory, especially focusing on JM 8th edition and Kaplan Step to CK. You will get at least 4 years of sample question discussion starting from 2018 to 2022. You will get a lot of unlimited software-based mock exam. We have subjective mock exam, we have monthly mock exam, and also 150 question mock test. There are Q banks you can also assess. You will get the course note in the software. You get the recording after the class. So if you can't join the live session, the recording will be there for 10 months in your software. So that's pretty much about it. So the classes are online, just like we have done today. It will be always on Zoom. And we take classes 3 days a week. And it starts from 7:30 p.m. Sydney time, and sometimes even goes to 10. Okay. Any question? All good. So I hope that you enjoyed the session. And if there is any questions about the course, feel free to inbox me, or you can always write an email to our email, which is the firstaidamc4536@outlook.com. You can also have a look at the chat box. Okay. The payment is $499 Australian dollar, and it is on just like a credit card payment. And Dr. Aisha, do you recommend studying the topics you teach in class to read in detail from John? Now, most of the topics that we discuss comes from John Mutter. So if you just go through those things, that is fine. There will be always some things which we will ask you to read it from JM time to time. So those topics only you need to do. And also your focus of reading is not only JM, because a lot of things are not available in JM and not well written. So sometimes you will need to take help from Australian guideline. So those guidelines we will show you that which one is the best one to read from. And usually questions come from those guidelines rather than just from a JM. So that is also important for your preparation. All right, so I will leave now then, and we will see you in the next free 2-week sessions class. All right. No, the software is not in your Facebook group. Software is only available after you start a course. So once you start the course, then you will be available to access that. All right. Thank you, everyone. Have a good night then. Bye.